come together to talk about it and decide together where we want to go from here. Justice and Beyond is always about coming together at the end and saying what action do we need to take and will take as a whole to figure out how to bring about justice on this issue. Tonight, we are privileged to have Dr. Kenneth Stephens with us tonight, who will introduce himself in just a moment. We do have a couple other panelists that will be joining us as well, too. But we're going to begin tonight. Dr. Stephens, here is a microphone. If you will introduce yourself and take about 10 minutes and just introduce yourself and then give us what we need to know regarding this issue of the high rate of deaths, both maternally and as children are concerned within New Orleans. Please.
Good evening, everyone. Good evening. Good evening, everyone. Good evening. Okay, that's better. Right. I'm Kevin Stephens. I'm an obstetrician gynecologist. I was the city health director for 8 years, and I've done a lot in this genre. So let me just jump right into it to let you kind of talk about my experiences and what we have done in the past, and perhaps more importantly, what we can and should do in the future. I think the first thing we talk about maternal and infant mortality in the same line, but those are two different lines completely. Maternal mortality is totally different from infant or fetal mortality. And so the first thing we have to do, what you do for maternal is different than what you do for fetal. Those are two different, completely different tasks, and you need to approach it from two different ways. So that's the very first thing. So I'll take, and neither one of them are easy. They both all are tough. But I'll start with fetal or infant mortality. So to give you some historical perspective on this, in about 1990, New Orleans had, and I'll give you some numbers in case you want numbers, because it's when you look at rates, you need to know what the rates are, and you can see how we can impact them. We had about a 16 to 17 deaths per 1,000 live births. So you measure infant mortality by deaths per 1,000 live births. In New Orleans, our infant mortality was about 16 to 17 deaths per 1,000 live births. To give you some relative numbers, in the state of Louisiana, the infant mortality is about 7.4 deaths per 1,000 births. So you see in New Orleans, we had over double the infant mortality. And then if you look in countries like Japan, their infant mortality is 3 to 4 deaths per 1,000 births. So even in the state of Louisiana, our rates of 7.4 per 1,000 is still almost twice high as countries like Japan. Now, when you break that number down, what you find out that it's not the same for the health disparities is the largest contributor in terms of infant mortality. So in the African American community, the infant mortality rate is anywhere from 16 to 18 deaths per 1,000 births. And in the Caucasian community, the deaths are like 5 deaths per 1,000 live births. The reason Louisiana has 7.4 is because Louisiana has 32 or 33% African American. And so when you have a large percentage of African American, that shifts your mean to 7.4. If you go to other states in the country where the African American population is 10%, because the African American population in this country is about 12 to 13%, you find that the reason we have higher infant mortality is because we have higher African American, and African Americans have 3 or 4 times higher infant mortality rates than the majority population, and that's why Louisiana is ranked 49th out of 50 states. So when you look at the healthcare rankings, what you're going to see, Louisiana and Mississippi, we are 49th and 50 out of all the healthcare rankings. But that's only and mostly due because we have a higher African American percentage in our population. If you control for the African American population and you control it to be equal and equal, what you'll find Louisiana is no better, no worse than anyone else in terms of the whole state. But since we have a 33% African American population, that shifts us to where we are the lowest or the highest. We're the lowest of the best and the highest, well, the highest of the worst and the lowest of the best. So it's a health disparity issue. So I need to make that clear. It is a health disparity issue. And so what we did to get at it, the Maternal Health and Child Health Bureau put out in 1990-92 a request for proposal to reduce infant mortality by 50%. And so under the direction of Sheila Webb and so forth, we wrote a grant to reduce the infant mortality by 50%. There were 10 cities chosen. New Orleans was one of the 10 cities. And to be honest, I was one of the original grant writers on that. And so we came up with all kinds of stuff that we would do. I can talk about that in a second. And out the 10 cities, New Orleans was the only one to lower the infant mortality by 50%. So much so, we still have grant monies coming in from the grant that we got in 1990. It's still in the city today because we actually lowered the infant mortality, and everyone was trying to figure out how do we do it. Well, I can tell you how we did because I was in fact, I was a medical director at Great Expectation for many years during that time period, so I was right front and center in the middle of it. The first thing, and perhaps the most important thing you have to do, you have to study the past. So what we did, what we call a fetal infant mortality review. In the fetal infant mortality review, what we did was we looked at every single death, and we looked at it in every single way. What was the age when the mother got pregnant, when she got to the hospital, what happened, was the baby born, when the baby got there, was it dead, what happened afterwards, what, when, where, who, why. We went exhausted in every single one. And we started to see a whole bunch of characteristics that's just starting to stack up. Before we do that, I just need to tell y'all, the problem in both maternal and fetal mortality is that it is not so common. It is more rare. So what you have to do, you have to look. You can't look at 1 month. You can't even look at 1 year. You have to look at 3 to 5 years to get enough numbers to make any sense out of it. And so what we did when we looked at the infant mortalities, we found systematic system problems, and we were able to fix them one by one. We had everybody at the table. We had all the hospitals. We had all the doctors. And we sat down, we went through these, and we saw, oh, this is what happened. Oh, this is what happened. And then we were able, that's how we were able. The other thing we did, we found out a lot of it was just health education. And so we were the first ones in the country to establish what we call community health workers. Community health workers, we call them, believe it or not, in New Orleans terminology, nanans and parents. So in our grants, that's what we call them, nanans and parents, which are just community people who we took in, and what we did, we trained them the equivalent of a certified nursing assistant, so they can know what high blood pressure is, they can know what diet and so forth, and we trained them to go into the community, find the pregnant moms, and help them navigate through the healthcare delivery system, whatever that meant. We know that the social determinants of health are more impactful than the medical determinants. In other words, what you eat, where you live, what you do is more important than what you take in terms of your medication. It has a greater impact. And so we were able to launch our community health workers. I had what we call our multidisciplinary rounds, where we had the community health workers, I had the nurses, I had the social worker, and I had myself. We would sit there, we would talk about patients. We would say how many weeks she is and what's her blood pressure, what she's doing, where does she live, where does she work, how does she get her food, how does she get to a doctor's appointment, how does she get her medication, is she taking her medication, what about the follow-up of the day? Y'all get the point. And so we did that on every single one. And then what happened, we saw gaps and opportunities, and I would tell the community, no, go and get her and get this medication. Girl, you got to take that medication, or else you're going to go into labor. That kind of stuff. And so we did that on I told them, get up right now and go and find her. Leave this meeting and go and get her right now. And that's what it took for us to ratchet down the infant mortality. So one of the biggest factors, the biggest single factor we have, and then we have reports. I could try to put my hands on one of them, but we did a written report on what our findings were and what our recommendations were. It was we had a grant, so it was a very official process. The biggest factor, though, were 85% of the mothers who had their babies that died were single women head of households. We, at Great Expectations, we couldn't do anything about it. I wish I could have found a whole bunch of men for them to marry or something, but in fact, at my church, they asked me now, do you know any men that we can come out and say, hey, Dr. Stephens, bring some more men over here, Pastor Manning, be careful now.
I'll do what I can
do. Well, that's the thing is, and you think about it. Why is that such a big problem? And I'm gonna ride with me for a minute. I work at pick your fast food place, Burger King, McDonald's, Illinois, and you get $10 an hour. If you get that, you probably don't, but if you do, you work 40 hours a week. That's $400 a week. You work 4 weeks a month. That's $1,600 a month. I don't care where you live. The least you can buy anything to rent is $700 a month. If you find something less than $700, let me know so I have a whole bunch of people that are looking that's decent that you can rent. And not just your rent. What about your food? What about your transportation? What about your telephone? What about your water bill? Your cell phone bill is $50 a month. And so by the time, if you don't watch it, and then the $1,600 is before taxes are taken out. So if you take taxes out and that sort of stuff, the livable wages is a real problem. And just go with me for a second now. So you have a person, a partner. You can call it. I learned to be, as Meghan Markle said, I'm learning to be sexually fluid. I don't know what that means yet, but that's what she said. She wanted to raise that son being sexual fluid. I said, what is that? Well, that's what I am. So. If you take take two people in one household, and they both make $10 an hour, now they have $1,600 a month coming in. And if $700 is for your rent, now you have a couple $1,000s that you can pay for food and other things. And so poverty and those type that plays. If you have more than one child in the house, you have school clothes, you have all kinds of stuff. It makes a tremendous difference having two people in one household contributing to income in one household than one. But anyways, so infant mortality, we have not done a recent infant mortality in the city in a long time. And one of the things that we should suggest to the state and to them to do, because it's a lot to do, we should do a refresh to see what has changed. The demographics of New Orleans has changed after Katrina. And then we need to look and see who, what, when, and where, and how. We had an influx, a lot of people left. The financial situation has changed. A lot of things have changed. And so doing another infant mortality review would be a great thing. And then once we do that, that will distill out the causes. It will tell you, out the deaths, 5 were because of hemorrhage, 5 were because of this, 5 were because of that. And then we can start to look better. So that's the one thing. On the maternal side, I don't know if you heard of
Pastor, real quick. Just a note to all of our participants, and I want you to be, and Dr. Stephens, I know you have to leave at what time, remind me? Close to 6. Okay, because I want everybody to be an opportunity to ask you some questions too. We take questions by index cards. So all of this information that Dr. Stephens is giving to us tonight, please key in on it and fill out one of those index cards with a question on it for him before he leaves at 6. Our other panelist is on his way, but on her way, I believe. So drop your question in either this bucket or that bucket and just get them ready, and we'll take them in just a little bit. Please continue.
All right, maternal side. I don't know if you heard of this lady. Her name was Kiara Johnson. Kiara Johnson, her husband Charles Johnson, has a real tough story. So they were in Mount Sinai Hospital, and his wife had a repeat C-section. And then after the C-section, she noticed there was some blood in her Foley. So he called the nurse and said, look, there's a little redness in there. What's going on? And they looked at, don't worry about it. And then she was getting uncomfortable, and he called them back and said, nurse, something's going on. This was like 4 o'clock. So they called the doctor. The doctor came in at 4 o'clock, and he said, I'm going to order a stat CAT scan. Stat in medicine means like right now. So the doctor wrote the order, and then so they were sitting around in the room, and 5 o'clock came, and he rung the nurse and said, are we going to get it? They said, we're too busy to be dealing with this now, so we'll get to you when we can. 6 o'clock came, nothing happened. 7 o'clock came, nothing happened. 8 o'clock, and he didn't want to take, quote, the stereotypical black male, angry black male, so he didn't get all out the box and start cursing and screaming and stuff. He just buzzed the nurse again. Do you know what we get? And it's a teaching hospital, so the medical students came in, the residents came in, and they said, okay, we're going to get to it. Just hold on, we're going to get to it. 9 o'clock came, 10 o'clock came, 11 o'clock came. 11:30, the doctor came in, and the doctor said, we need to take her to surgery right now. So they took her to surgery, and on their way in, the doctor told him that, look, it's going to be about 15 minutes. I'll be right out. Everything's good. And then he said that's the last time he spoke to his wife. When they got to OR, she had 3 liters of blood in her belly, and she coated on the table and died in the OR. She was bleeding the whole time from 4 o'clock all the way up to 11 o'clock. When they finally got her to surgery, it was too late. And then he testified to Congress about this. In fact, I don't know if y'all know it, but just before the shutdown, he got a bill passed, actually House Bill number 1318 to be exact, and then he got President Trump to sign it. And the way he got President Trump to sign it is that he went on tweet and he went on the social media and he really badmouthed the president, so to speak. And the president signed it. He got forced through the political pressure of Me Too and everybody to sign it, and so it's into law. But anyways, that's you can Google. It's Kiara, Kiara, I think, for Kiara for Moms or something. There's a website, and then you can go in and find his story, and he has testified all over the place. But back to maternal mortality. A third of the deaths happen before people get to the hospital. A third of them happen while they are in the hospital. And a third of maternal deaths happen after they discharge from the hospital. And again, the problem is it happens so infrequently that it's hard to get your arms around it because you have a death at one hospital, maybe 1 or 2 a year. And then in 1 or 2 a year, it's so small of a number, nobody really sits and thinks and counts it. So you have to really look at it over 3 or 4 years. Of interest, though, and I have an article that y'all can, I share with y'all can send to everyone. Maternal deaths in this country have been rising all over the country for everybody, white, black, everybody. It's disproportional in African Americans. Maternal deaths are 3 to 4 to 5 times higher in African American population than the majority population. And then so there's one state that saw this, and the state decided we are going to change the system, and that was California. So California over the last 10 years have been able, while everybody else in the U.S., their maternity mortality rates are going up, California cut that rate in half. And I have an article here that I can share with y'all to read further about how they did it. Guess what the first step they did to reduce it? Maternal fetal mortality review. They did what I said for the infant mortality. It starts with you got to do an exhaustive review of every single death. You have to look at when it happened, where it happened, why it happened, who it happened to, what time of the day, what weekend. You have to look at all this stuff to see. And so that's what they did the first thing. And then what happened is that you start to see patterns when you do enough of them. And then they were able to start to work. One of the things they noted is that in the delivery room, the delivery rooms were not readily available for bleeding. So when you have bleeding, the delivery room, they have to call and go get blood. They have to call over here. They have to wait over here. By that time, the patient could die. So what they did, they instituted a hemorrhage station inside every delivery room in every hospital. So if the mother started to bleed for whatever reason, like in Kiara Place State, that they had, by the time they got the blood, it was all because the doctor was going into delivery. And he was thinking, well, it's going to be 15 minutes. So he wasn't even ready for when he opened the belly. And so when you're not ready, it's hard to respond. And perhaps if they were ready or more ready, then they could have saved her. But anyway, so that's one of the things. The second thing I want to highlight too, which is something that we as obstetricians, and I have to be honest and transparent, it's C-sections rates. A lot of times we induce labor, a lot of times we do C-sections, and then we have been trying to reduce C-section rates. And it's very hard to reduce C-section rates. But in California, that's one of the things that they have talked, because when you have a C-section, in this case that I just talked about, the maternal mortality, she had a repeat C-section. And whenever you have surgery, there are risks associated with surgery. So that was, so what they tried to do was to reduce the cesarean section rates. But it's hard to know the cesarean section rate. If you go to a hospital, go to a doctor, you don't know what their rates are. You don't know what the hospital C-section rate is. And so you can choose what hospital and what provider you go to that have lower C-section rates, if that's what you want to do. Some people, there is a push. I mean, this is very complicated, and I don't want to take too long because
I got several questions over here, Doc.
I could talk forever because this is I live and breathe, and
I got you.
is that
take about maybe 60 more seconds. Then I want to
okay?
get to some of the
I will
questions.
just say this, and then I'll take the question. Some women come into your office and say, Dr. Stephens, I want a C-section. I do not want to go to labor. I want an elective C-section. I want you to set it up and schedule it and do it. And in some places, you can do that. Most doctors like myself, we say, no, we don't just set you up for an elective C-section. And that's a big debate in our profession about that. But anyway, all right, let's take some questions.
Let me just clearly, though, should we be suggesting or urging our people that if they want a C-section, if that's just an elective C-section, to urge them not to go that route?
Yes.
That our young black women should not be getting C-sections.
You should not electively. If you need it, you got to get it.
Right.
But
not just for your convenience.
Not just for your convenience. And in fact, one of the reasons our infants, remember I told you, there are two sides, infant and fetal. One of the reasons we have higher infant mortality is failure to do a C-section in a timely manner. That you have fetal distress, and they say they don't do the C-section when they should. So it's a tough area to work in, and it's tough because you really have to have good lens, and you really have to understand there is no simple yes, no, wrong, right, and you have to really look at every case individually, and that's why the fetal mortality conference and maternal mortality. All right, let's take some questions.
Thank you. Mr. Ted has a question.
I was in that Great Expectations campaign. I did the training on Wednesday night. It was a grassroots campaign door to door. It was a grassroots campaign going door to door to reach the community. But one of my issues, I was just going to say I was there. It was real important. And it went door to door to find who was pregnant, what they needed, and so forth. And that reduced infant mortality. Today, you just said what the infant mortality rate still is. We have a state that just passed an anti-abortion law, so it's concerned about the unborn, but does nothing to reduce infant mortality for the people who want to have their babies. And once the baby's born, they don't want to give them health care or anything else. So that's just a comment, maybe.
Thank you.
The next question is, how would single payer or Medicare for all improve this situation?
Well, it's not a function of payment. So the money is not the issue. In the case of this Kiara, she had insurance. She had private insurance. I can tell you, if Kiara was Drew Brees' wife, that wouldn't have happened. If Kiara was Drew Brees' wife, even, to be honest, if she was even Stephen Curry's wife, it probably wouldn't have happened. And so it's not only just race, even though race has something to do with it. But it's really it's a tough. So to answer your question, it's not a financial. We in the insurance company industry, what we did, we said we'll pay doctors the same whether you have a C-section or vaginal delivery. Guess what it did to our C-section rates? It went up. If you pay them the same for a vaginal delivery or a C-section, that had no impact on your cesarean section rate. It's not about money. That's not the issue. So the single payer in this genre won't mean anything. I think what Ted said has more to do with it.
Thank you.
Uh-huh.
I've got a book here, Black Mother Dying, and I want to read a passage out of here. She was admitted into the hospital, St. David's in Austin. She had low blood platelets from the beginning of her pregnancy. They don't know why. She went to one visit like 5 weeks before she was to deliver. Her blood pressure hit 240 over 180. A doctor admitted her, right, that day, telling her she needed a C-section right away, even though it's 5 weeks. Then around 3 a.m., a doctor came to the room and introduced himself. He advised us, although I was having some complications, he felt it best I go home and schedule an appointment with my OBGYN for later that day. I advised him that another doctor felt it was best to admit me into the hospital now and have the baby in the morning. He immediately responded, well, it is costly to your insurance to admit you on an emergency basis and keep you overnight. We do not want to make you or your insurance pay all the money that it would cost. I mean, here you have this African-American woman, and what I translate that into is this white doctor, because I talked to her, saw her as an African-American woman. He would not get reimbursed by the insurance company, so he was sending her home because even though she's, a social worker, 20 years in the field, degree from Purdue, he is making his decision based on whether or not he and the hospital are going to get reimbursed for keeping her.
Thank you, sir. Thank you.
Well,
Dr. Stephens.
let me respond to that. As a doctor, we don't get paid by the visit. We don't get paid by visits in the hospital, out the hospital, in the office. It doesn't matter how many times you're in or not in. We don't get paid. The hospital does not get paid by the days, the per diem. That's not how they reimburse. They're reimbursed for the most part, and most insurance, I don't know what state it was, but in this state,
Texas.
It's a global OB payment that we pay $1 amount for everything, all inclusive. Now, the NICU, when you have a baby in the neonatal intensive care, that is by day. But for the hospital, whether you come 10 times or one time, they still get the same global fee. The doctor, as an obstetrician, I wish I could give more than one for some patient I had more visit with, but they paid me one fee, period. No matter if I do a C-section, no matter if I did a vaginal delivery, no matter if I stayed up all night, no matter if she delivered in the ambulance on the way to the hospital, I would still get the same one fee.
But why would he send her home saying the cost of the insurance would be too high to keep her in?
Well, in case you haven't figured this out, now some people do lie, and some people do misquote the truth for convenience for their own lens that they see, but that's not how it works.
Why would it be in his head to say that? Where'd that lie come from?
He might have been just trying to move her out the hospital just to make space for somebody else, right?
So he gave her a reason that she would believe.
Right.
He gave her a reason that she would believe. That's why. That's not the reason. I tell her, I work in the insurance company every day.
There's a myriad of reasons it could have been. But thank you for that passage, and thank you for that clarification, Dr. Stephens. Next question.
Dr. Stephens, I know your area specialty is OBGYN. However, Channel 4 recently did a news show highlighting African American women dying more often than white women. Can you elaborate on this, or expand on this rather?
Are we talking maternity, or are we just talking in general?
I think it was maternity. Oh, in general? Was that?
Well, okay. Okay. Well, again, this is what I live every day, so I know a lot of stuff. So I'm gonna try to be brief and get to the point. the mortality rates, when you look at death rates in the United States from birth based on age and sex, is interesting. For a white female, from birth, the life expectancy is about 79 to 80 years of age. For an African American male, from birth, his life expectancy is 68 years. There is a 12-year difference. And the question you ask and you can answer is it genetics? Do black males have some default gene that makes them die sooner? Or does a white female have better genes or something in their body that make them? No, it's environment. It's the environment. It's not. If you go outside the United States and you go to other countries, you will see there is not that gap. And so with black females and white females, and again, there's about a 5-year gap between the life expectancy from birth for a black female and for a white female. So yes, there is a significant, that's health disparities. It's what you eat, it's the stress. Even when you control for African American females, the ones who are college professors and so forth, they still have higher mortality, they have higher infant mortality, and we have been trying to explain that. And then some of the things that we're thinking is the stress in the life, the stress of being a minority in the majority country. Yeah.
Thank you.
It's very complicated, and it's a whole bunch of things. It's not just stress. It's also what you eat. It's also when you eat. It's also it's just a litany of things that you can see that can take its role. And if you look at obesity, we have high blood pressure, we have higher hypertension, we have higher obesity rates, and exercise, smoking, what you drink, all that. It's a lot of things, but at Justice Beyond, I think we can start to have as I would call it, a healthier lifestyle. And it's stress. I mean, if you look at a lot of, even people in our church, I know they work 2 jobs. You have to work 2 jobs just to make the ends meet. And so all those stressors can make a difference, as opposed to a housewife that works, even though that can be very stressful, particularly my wife, because I admit it.
I'm stressed right here just talking to you, listening to you. Yes.
Sometimes we aren't prescribed the best meds, because I know for my high blood pressure, the one they were set up for made me cough so much, within a month I told them this is not working for me. So just the quality of health care that we receive, or the lack thereof.
Next question.
Okay, first I want to ask this, because I was looking at, that was one person I bought. That's a lot of ideas and patents that went to DOD, that I got accommodation from Benny Johnson, but I still need to get royalties off it. Like I said, still on the market. Now, one thing that I seen is Louis Sullivan. He was health in Washington, D.C. And they had, I think they said they had 2. They had a black and a white. That's a lie. I don't know if it's a lie or not. So they were saying that the women who had addictions and were pregnant, it was hard for them to not take the drugs while they was pregnant. So that probably induced drug into the baby system. Is that one of the kind too, that the infant mortality rate is down? And as you was talking about all the bills that the black, not just black, everybody have to pay. When I went to City Hall and I was talking about qualification, one more qualification, I got to call Mr. Lady, should be Wi-Fi, because now you cannot exist with Wi-Fi. You got to even apply for jobs, which lowers the income in the home too. You have to apply for jobs. Some people only send you an electronic notice, so that takes away from the income in the home as well. But when I had that with Louis Sullivan, and I said, and I worked at the post office, and this guy would go in and out, in and out, in and out on drugs. Well, something must be wrong. What's wrong? And I thought, and I thought, and I thought. People used to ask me a question. I said addiction. And that's what the cause. If they could put the addiction into remission, then that might help the people as well. So the man told me when I wrote the letter, he said, oh, you could be a billionaire. Well, no, I can't. He said, why don't you patent it? Yeah, by the time I patent it, y'all going to say, y'all already have it. So this is one of the things I'm finding too, that they could put addiction into remission to help with drug addiction, whatever, to help with drug addiction. And I've been doing this since 1997 or further. Thank you.
Well, I could just comment for a second. Opioid use is a big problem in this country. In fact, the addictions that we're having have decreased the life expectancy. In years, we were going up and up and up, and over the last couple of years, we start to fall down due to suicides and overdose from opioids, and that's why there's a big push in our country, and that's a whole nother study and a whole nother talk about opioid addiction and what we can do about that. I have to come back some other day and deal with the opioids.
we got 5 questions up here. I know you have to go, so I want to be respectful of your time. But listen, one of the major actions that you suggested that we can take is by doing this maternal and infant review. How do we go about getting that done?
Write a letter to Dr. Gee, the state health the Secretary of Health.
So somebody writing this down? We would love to have you at our pillar meeting on Tuesdays.
Okay, I'll look at my schedule and see what.
At 12 o'clock, Broadmoor Community Church. But for someone else who's writing this down, to continue to tell us, please.
Just write a letter to the governor, and the governor will give it to Rebecca Gee, Dr. Gee, G-E-E. She is the Secretary of Health of the state, and ask her for a review, maternal infant mortality review of the Orleans Parish area, and then ask her to fund it. She has the resources, she can do it.
And the last time this was done was when?
I don't even know. It's been done a long time ago, maybe 2006. Okay. Maybe that is the last one I know about has been at least 10 years ago.
And states that are reducing the rate do it how often?
Well, it's the problem. None of the states are reducing their rates. All the rates are going up, and now California just did it, and you can look in the article. But states are beginning now. They're beginning to do it. My obstetrical association, they have a whole national division that help states do this. So there are resources out there to help this thing get done. So we just have to get the governor to request and to push it. The hospitals and the doctors are not in any interest to push it because, number one, it takes time and no money from it. So that's where money comes into play, because you don't get money for doing the infant fetal mortality review. I mean, you just sit around and get beat on the head and look at all the kind of stuff. They don't even want to know it for some degree. And number two, it takes, it's so infrequent. The deaths are not like once a month, maybe even once every 6 months. And so it's so infrequent, you don't really get the impact of it because it's not very frequent.
Okay. One last question. For young mothers right now, young African-American mothers, what is your greatest piece of advice for them?
That's great. That's an excellent question. And it's just not, it's mothers and everybody. The first thing you have to do, it's your mental health. That's the very first thing. Stress, stressors, relaxation. We live in a very, very tough society. And we all have, if you don't have racism, you have sexism, you have classism, you have all kinds of stuff. We have some kind of ism that's going on. So learning how to cope and how to manage and how to navigate through that is the worst thing. And I think part of realizing that you are valuable. You are, no matter how you look, no matter how your skin color, no matter, you are a valuable person, and every person counts. Every person counts. So that's the first thing. The second thing, So in our church, I know you say no perfect people are allowed. We have every person count, every dollar count, and every minute count. So that's how it looks like. But the second thing, though, is healthy lifestyle. And healthy lifestyle is simple. Eating fresh fruits and veggies 5 servings a day. And cutting back on the meats. Cutting back on the fried foods. Cutting back on the fats. Just exercising. I mean, so when I went to Africa, one of the things that you find in Africa is that everybody's walking. They're all walking in. But you know what? You don't see the obesity rates that you see here. Why? Everybody's exercising. They walk everywhere. So we need to have community walks, bicycling. We need to really enforce healthy activity, physical activity. And the rule of thumb is you need to have 150 minutes every week of physical activity. 150 minutes a week of physical activity. You need to have 5 fruits and 5 veggies every day. And just doing that, it's not just, so we worry about the fat content, but if you eat the right stuff, you're not hungry to eat the wrong stuff. And so I think if we can, and perhaps we can send out some, one last little thing about that too. So Tulane has a big thing going on with community wellness, and maybe I can, they have a free cooking class that they do for community members to show us how to, y'all heard of DASH diet, the diet to lower blood pressure, the Mediterranean diet? Well, researchers now have distilled all this stuff down now to some simple steps that we all can take. And they are out there teaching us in the community what are these simple steps that you can take to help increase your life.
Okay. All right. And I promise you it's the last question. Then you're about to leave. But people keep whispering in my ears. So how can women here in this audience and even men act as advocates to bring down this high rate of mortality amongst infants and mothers? What can we do?
Well, as I said, the first thing, you have to get the root cause. And so it starts way before the mother gets pregnant. And that's the first and perhaps the most important thing. You got to start. You can't wait till she gets pregnant to start working on these other things. So we have to start very early in the process. And then the diet, exercise, that kind of stuff. Number 2, like Ted said, the community has to go out and find these mothers, and we have to tell them, let's talk, let's just work with them. How you doing, sister? Are you going to the doctor? I can't tell you how many of our pregnant moms don't get into prenatal care until the 5th or 6th month. And by that time, all my testing is all done. I mean, all high blood pressure, all this other stuff. So we have to start before the pregnancy, and as soon as we see that the pregnant mother, so a simple thing to ask, you see someone pregnant, who's your doctor? Just ask them, who's your doctor?
That's good. Good. Who's your doctor?
And they say, I know Dr. Stephens. He is a great guy. He just wonderful. Oh, no, maybe not. But
who's your doctor? That's
right.
That's
a good way to find out.
Yes, absolutely. Yes.
My daughter-in-law is a doula with the young woman who unfortunately is stuck in traffic, who's supposed to be here tonight to talk about this. So Miss Ashley Hill Hamilton is stuck in traffic on her way from Baton Rouge, the person who was sort of going to be a special person here with a lot of experience with black births. My daughter-in-law is a doula in that same practice. And the story that the man who stood up, I don't see him now, but the man who stood up about that story in Texas, almost exactly, word for word, this happened in New Orleans just 2 weeks ago, and it was a client of my daughter-in-law's and midwives and so forth. And the mother and the grandmother and the young mother who had just given birth hours before, the young mother was being sent home. She had just spiked. Her blood pressure had just spiked dramatically. And the doctor said, well, we're going to send you home. The mother and the grandmother fought the doctor and insisted that this woman spend the night. She had had lots of prenatal care. She was in good health. This was something that was just, I don't believe this would have happened to a white woman. I don't believe the white woman would have been sent home under those circumstances. And I guess that's what I find, and I don't know whether you read the New York Times article on blackbirds, but it was also around New Orleans. A lot of it was based here.
It was all Louisiana.
It all was, okay, yeah. It was an amazing article.
And Michael Jones, Dr. Michael Jones, I do want you to come to the stage too, because we're going to ask you some questions too. But there has to be, what we understand, there has to be some degree of prejudice and racism that's impacting.
Don't mistake me at all about that. And let me be even more transparent. I'll take a minute here because this is something near and dear to my heart. My own sister had cancer, and she was in the hospital. And then they would not give her, she had what we call an SBL, small bowel obstruction. She did not have an IV. She could not eat because she had bowel obstruction, and she did not have any fluid for 7 days. So much so, I called them, I wrote them, and I got on an airplane to go up there to get them. They said, when are you coming? I'm saying, I'm coming Friday morning. So I got there Thursday night. When I got there Thursday night, I walked in my sister's room, and the minute I walked in, she saw me, and she started telling me, and I couldn't tell what she was saying. She was saying, I don't know what she was saying. I said, that's all right, we got it. And then the next morning, I went into the hospital room at 8 o'clock. I told them I was coming in. When I got in the room at 8 o'clock on Friday morning, my sister had an IV. She had Kepper. She had what we call hoses on her legs for compression. She had a plate of bacon and eggs on the plate. She had a cup of water on the thing. And she had a bowel. She couldn't eat anything. And so when I went in, that 8 o'clock on Friday morning, they had set a stage of, I hit the, well, y'all don't know the tough Dr. Stephens, but
you took the collar off. You took the collar off.
And I said, but that was, they would not give my sister a crumb, and she died that night. And then that's what happened with this other guy, Mr. Johnson. He was talking and brothering the nurses and so forth, and they never did. So yes, there is a degree of, I don't think it's financial, that, as I said, I think it's just straight up racism. And then just to tell you a little bit more, because this was near, and my sister just died a year ago, and so I'm still hurting from that. And it helps me to talk to you about it, so y'all gonna be my therapy session. When I called them and I talked to them, I said, let me talk to the doctor. And the nurses, they started calling me Kevin. And in the hospital setting, as a physician, you never call a physician by their first name. And every time it would call on the phone, Kevin, what do you think? Kevin, what do you think? I said, look, I'm not Kevin. I'm Dr. Stephens. And then they started writing me emails, and those of you know I'm an attorney, so when they start, I said, okay, let's bring it on. And so they started writing me emails back and forth, and I really made a and then all of a sudden, I got a call after about 5 emails, because I was making my case to sue them if I had to. And then all of a sudden they said, well, Dr. Stephens, we're not going to do any more emails now. we don't do anything now, so we're just going to wait until you get here. And it was that bad, and that was just pure old racism. Yeah. And I talked to the hospital administrators. I went and I said, I really voiced my expression because I don't know, not that I am anybody, I'm not anybody, I'm a person, and my sister's a person. And then she just deserved to be treated with dignity. Yes. And you have your rights as a patient. And I didn't want to present myself as an angry black male doctor, but you know what? The goat had to come out.
We are certainly praying for you, and we appreciate you being here tonight. Please join me in showing some gratitude for Dr. Stephens. Thank you for your passion. Yeah, talk to him on the way out. Listen, okay, we appreciate it, and thank you for being here again tonight, sir. We have on the stage now Dr. Michael Jones, and I'm going to let him tell you about himself and what he sees as critical to this issue and what we need to solve it as well too. And we appreciate you being here, Dr. Jones. There's a microphone there Please use that. And we're going to ask you some of the questions that we have remaining, if that's all right, as well, too.
That's fine.
All right.
So I'm Michael Jones. I'm a cardiologist. You can't hear me? Okay, so I'm Dr. Michael Jones. I'm a cardiologist.
Dr. Jones, please, I'm sorry, real quick. I need to say this. I'm remiss in not saying it. Listen, everybody, we collected about $60 for our meal on tonight. Now, that's good, but it's not great. And what that means is we're about $30 short of where we need to be able to have another meal next week. According to what Dr. Stephens said, it's going to have a little less meat in it next week so we can get a little healthier. But we still need for you to chip in and make a little donation to it if you could. Thank you so much. Dr. Jones, back to you.
Okay. So as I was saying, I'm Michael Jones. I'm a cardiologist. So I was trained in internal medicine and cardiology, but I also did a year internship in psychiatry. I'm originally from Georgia, so I did all of my stuff in Georgia, except for my cardiology training was done here. I come from a little bit different view in place than Dr. Stephens. I have always been a solo private practitioner. I have always taken care of people despite what the difficulties were, as though they were my mom, dad, sister, brother. And one of the major problems that I see is our fee-for-service industry that we call medical care, medical insurance. I don't think there's any way to look at this other than simple and straightforward. We'll first take infant mortality, and then we'll take life expectancy. So these are two things that are quantifiable, okay? You can easily track what year age people die at in your country. You can also easily track how many kids are dying per 100,000 per country. When you do that, the United States falls number 26 among all countries. That puts us below places that you would call banana republics even, okay? That means that every European nation has a better outcome than us except for Russia. Now, why is that? Universal health care. Now, these things are not hard to understand, okay? I don't want you to have to think too hard about this because you actually already know this. You actually know it. You just may not have heard it in a certain way. So, how many countries do you know of that elected universal health care and thereafter it being implemented, they then got rid of universal health care? Say it again, ma'am. None. So, if what you got wasn't worth the purchase, you give it back, don't you? Okay? So, how many times have you changed insurance provider, though? Probably a few times, right? So, the obvious circumstance is that you get better outcomes on the front end, infant mortality, and the back end, longevity, when you have universal health care, period. There's no question to it. So your question should be then, why do we have for-profit medical insurance, right? And the answer to that is simply this: greed. The health insurance industry makes $1.3 trillion, not billion, trillion dollars each year. 1.3 trillion. Do y'all have any idea what the national debt is? 27 trillion. Hence, if you took 20 years of taking the money from the insurance providers and put that money towards the debt, you would eliminate our debt in 20 years. Do you all know what the Medicare budget is per year? $600 billion with a B. Do you know what the military industrial complex budget is? $600 and something billion. Okay? So, if you took half of the military budget, and understand, no other country that considers themselves our rival, that we are frightened of, China. No other country that has the might to contend with the United States spends a half of what we spend on the military. So if you took $300 billion from the military budget, putting us on par with our most supreme rival, we would then be able to put that 300 with the other 300 with the other 600 billion from Medicare already, and now you have $900 billion. You think you could probably fund the rest of the individuals who are not seniors with that amount of money? Okay, so you can. But how about this? How about you say we no longer do insurance for profit? Hence, that 1.2 trillion that we're putting into that, 1.3, excuse me, that 1.3 trillion, let's say we slice that down and say at least 25% of that must go into the government-sponsored insurance. Now you have another 400 billion. You add that 400 billion to the other 900 billion that I told you, you think you can take care of everybody with that? And I guarantee you that you will decrease infant mortality. I guarantee you will decrease the mother's mortality. Now, I disagree with Dr. Stephens, unfortunately, on some of the points there. I'm a very simple person. I don't look at things from what's going to be of the greatest benefit for me, but what's the greatest benefit for everyone. Okay. So with that in mind, I think that we all should pony up our 20% on our taxes. If you pony up your 20% on your taxes, now we get universal health care for everyone. But guess what else? You now don't have to spend the $12,000 you're spending on health insurance. Okay? And I'm giving you a discount, okay, on that. Because if you're older, you're not spending 12. You're spending 20. If you have 3, 4, 5 members, like I have in my family, I would have to spend $36,000. So I don't actually carry insurance. I don't. I pocket what money I save from my insurance, and then when things become bad, I pay for it out of pocket. And I'm able to actually go to the doctor that I want and say, here is my money. Take care of me the way I want to be taken care of. Because with insurances, you don't get to choose your doctor. Okay? You don't get to choose your hospital. You don't get to choose your emergency room. Am I correct? Okay. How about this? I'm board certified cardiologist, nuclear cardiologist, internal medicine doctor with 20 years of experience. I decide and say for Reverend Manning that he needs a medicine called Entresto. I then tell him he needs Entresto. I send him to his pharmacy. He goes there with the script that I've written, and does he get his Entresto? No, he does not get his Entresto. Not only does he not get his Entresto, but he saw me for 15 minutes. Let's say he had Medicaid by some chance, okay? I get paid $45 per 15 minutes for a Medicaid visit. That immediately becomes $22 because half of that is my overhead, yes? So now he's seen me, I've exchanged my knowledge to him for $22. He's got a prescription that he then takes to his pharmacist, and then they tell him he can't have his medicine. And then what do they tell him? You got to ask your doctor to get a prior authorization. Now, how many of your doctors do you think, even if your insurance paid them twice the Medicaid rate, which gets them down to $45 for that 15 minutes, right? How many of your doctors do you think are going to go that extra mile to now spend 15 to 20 to 30 minutes on the phone to ensure that you get your Entresto? And who benefits from that? Entresto costs $300 per month. Lisinopril costs $10. If I can't get you your Entresto, I'm going to have to give you Lisinopril. So who benefits? The insurance company pockets $290 for as long as I cannot convince them to give you your medication. Okay? The simplest way to improve health care for the vast majority of Americans is universal health care. There is no other understanding of it. The only way you have a different understanding of it is that you have a dog in the fight, i.e. the insurance company, a politician being funded by an insurance company, or someone who works for an insurance company. It is also absolutely fact that we come through the hospital. I've worked in hospitals for the last 20 years. We come through the hospital, social worker stops me, she's been given a duty. She is to make sure that all insurance monies are accounted for and let the doctors know when the patient has to leave the hospital. Absolute fact, not a question about it. okay? And she will come to me and say, I understand that Miss So-and-so's blood pressure is high today, Dr. Jones, but her insurance company is not going to cover her hospitalization for today. It absolutely happens, no question about it. We send people from the emergency room, not I, but my other fellow doctors, send people home from the emergency room who have blood clots, diagnosed blood clots in their legs or in their lungs, and say, hey, just take this pill. It's guaranteed to thin your blood. The medicine is guaranteed to thin your blood. But if you have clots, wouldn't you want to be in the hospital for a day or two?
Dr. Jones, sorry to cut you off here. We got some questions that we want to get to.
And I'm actually done with that, okay? So you guys go ahead and ask your
questions. We got some right here at the table. And take about, I hate to restrict you, but we got to get these questions.
I'll be done.
2 minutes on each question.
I'll be done.
All right.
Okay, so earlier we heard Dr. Stephens' piece on racism in the field, and we'd like to hear yours. So would the same logics that are being applied to African American women be applied to white women? Or in other words, is there some piece of racism going on?
So let's address that with two specific things. There was a study called the VA Heart Study. This study showed that racism was endemic in the field of medicine. And this stuff should not be hard to believe. I mean, come on. When I leave here tonight, I will worry that I won't make it home. They found out that the black men receive fewer target therapies, i.e. coronary artery bypass, graft, and stenting, which meant that they died earlier. They have studies that look at, there are over 30,000 studies that look at racism in the medical profession, and over 1,000 have been peer-reviewed multitude of times, and they show things as crazy as this. You can take a teenage child in the emergency room who's there for a pain syndrome of some sort, and when he or she leaves the hospital, he or she almost always got less pain medicine than their white counterpart. Almost always, okay? I could go on, but the point being, there will absolutely always be, in a system that we have people looking at each other differently, there will always be this notion. But one way to cut that back a little bit is to at least have the doctors not able to have in their mind that there's a financial difference in the individuals, okay? When people take care of a Medicaid patient, they look at them different, okay? You'll hear people say, oh, I don't want to go to that doctor. He's a Medicaid doctor. Okay? And you'll also hear doctors saying, oh, I'm not taking Medicaid. And it's unfortunately that they think Medicaid is an African American product, a Latino product. And that's the way they treat those clients.
Thank you.
After reading the story of Dr. Shalon Irving, a CDC epidemiologist who died after childbirth, would you agree that healthcare disparities are not due to race, but instead due to racism?
So yes, that's obviously the case, but unfortunately human beings have not become evolved yet enough to look away from our identity as the source of our value and hence another person's value.
The next question is post-traumatic enslavement disorder being considered in research?
I think that is, but there's something that we touched on, like there are some genetic predispositions of African Americans. So again, I'm a cardiologist. We've studied high blood pressure all around, and we call high blood pressure benign hypertension. Benign meaning it's just blood pressure. But no, then we changed it. We said it's essential hypertension. Essential meaning it comes out of nothing. We don't know why it occurs. But that's not really quite the case, because you can look at pockets of population. African Americans have higher blood pressure than Caucasians. African Americans have higher blood pressure than Asians. African Americans have higher blood pressures than Latinos. But outside of the United States, the African populace does not have elevated blood pressure the way that we do. So then you have to ask a question. And I don't want to use too many fancy words, but you guys have heard of the diaspora, the movement of Africans from Africa to the New World. Well, who would survive such a trip? The person who could retain their water base while they're on a long trip, someone who does not have a propensity towards diuresis, urinating out a lot. Well, what happens if you retain fluid? Your blood pressure goes up, yes? So it is quite possible that we have genetically selected out those individuals who would have a greater propensity for higher blood pressure. And we've actually done the studies that show that African Americans run a higher renin level, okay? And we utilize this in terms of the medicines that we choose for African Americans. But it's quite possible that we have genetically selected out the individuals who would have a higher propensity for high blood pressure via the African diaspora.
Thank you. Next.
On a slightly different note, cigarettes versus jewel pods. How does it hurt us?
What's that?
Cigarettes versus jewel pods. How would they
What
help?
is jewel pods?
Like the e-cigarettes.
Okay. So cigarettes are far more unhealthy than any other form of tobacco substitute. Okay, if you think about the way we treat nicotine addiction is, we give you either nicotine gum, we give you nicotine patches. That's really what those e-cigarettes are. So I actually recommend e-cigarettes for my patients who smoke and cannot stop smoking easily. For cigarette use, it's the carcinogens that are the problem. It's not the nicotine. Now, yeah, you can be a little hyped up on nicotine. Nicotine itself can drive up blood pressure somewhat, but that's not the primary reason that we're stopping people from smoking. We're usually thinking about lung disease, emphysema, bronchitis, lung cancer.
Thank you. The next question is alcohol, marijuana, and kratom, I believe. Which is healthiest?
Okay, you got to tell me what that last one was.
Hey, spell it.
Kratom. Kratom.
That right?
I have no idea what that is.
Who submitted the question? Can you clarify? Okay. Marijuana. What was the other one? Let's stick with marijuana and alcohol. What was the...
Okay, so alcohol. If alcohol was created today, we'd probably have it outlawed. Okay, so I like to drink. I like wine. Okay, but alcohol is highly addictive. You do not find people breaking into convenience stores for marijuana. You don't find people in the hospital dying from a marijuana disease. But you see people in the hospital detoxing, okay, which can kill you, quite honestly. You see people in the hospital with liver failure, hepatitis, okay, jaundice, right? You see people who go alcohol crazy, right? Their brain gets so screwed up that they behave like they're schizophrenic or something like that. They're out there talking to themselves, walking around. You've seen all of these problems. So alcohol in excess is a horrible thing.
All right, thank you. And that kratom, that's a new one. Somebody's on some, I don't know. Somebody's on some new stuff in there. I don't know what that is. Hold on, next question.
Kratom is a Chinese herb that a lot of people who use heroin use that to get off heroin. It's really becoming quite a thing. There are kratom coffee shops.
You've actually jarred my memory now.
Yeah. Oh.
So we'll first we'll hit marijuana. So marijuana, I don't think there's a great use for marijuana, not medically. There are two areas that I would use marijuana. Okay, I would use it in cancer patients who cannot eat. It stimulates appetite. It reduces nausea. I would use that similarly in HIV patients who cannot eat. The other place marijuana can be used is for a pain adjunct or in isolation. But I think that needs to be very carefully monitored because although there are not a great deal of side effects of marijuana, I can't see why anyone would want to be high for 4 to 8 hours. I mean, you should want to have agency of yourself. So, if for all of you who want to use those drugs, just think if I was smoking weed and then you came in to see me. And think about the way you are when you're on weed, and ask yourself, is that what you want your children around? Do you want to have a reduction of your ability to respond quickly and appropriate to circumstances? Now, the kratom that she mentioned, there are lots of different ways to get people off opiates. I've heard about kratom. There are not too many doctors here who are using it. I actually heard about it on NPR. Okay. And there are a number of Asian and Indian, and Asia is India, but there are a number of Eastern countries that are using it to get people off opiates. And they say it works wonderfully. There are some people who are importing it into the U.S., and they're using it, but I would tend to think that they're using it without an okay from the FDA or whatever, but there has been success with it. I actually use Suboxone, which is buprenorphine. Have you guys heard of this? So I've been running a detox program out of my office for the last 2 years. So I use Suboxone, which is a combination of buprenorphine and naloxone, to detox patients. Some people ask me, well, you're just replacing the opiate with another drug. Well, yeah, but I'd rather know that you're getting a drug made in a lab that's clean of all the other impurities, that I'm required to monitor your use in terms of checking your pharmacy and the board of pharmacy to see how many scripts you've gotten, rather than have you outside shooting smack, right? That makes far more sense. You don't get hepatitis C that way, right? If you're not shooting in your vein. You don't get HIV if you're not shooting in your vein, hopefully, okay? So it's a cleaner way of doing things. I have actually been able to get patients off of opiates, and usually they're doing pills like OxyContin or Lortab or something like that. I've been able to get patients off opiates as early as 3 months into therapy, but then I have some patients who I've had on therapy for 2 years. I'm sorry, say again, ma'am?
What was that? Repeat that, please.
I said, don't you think I need to get paid, or although they do the prototype, my idea suggestion that went to Maryland from Washington, D.C. was to put craving into remission, because addiction is what keeps people involved in circles, and this was my practice. Even though they do prototypes, I think I should be paid.
Okay. Dr. Jones, she should get... Yeah. We're going to agree with that. Yeah.
Absolutely.
Yeah.
Absolutely.
Absolutely. If that was your prototype, I think you should get absolute credit for that.
And this is my license tonight, and I think it was 1990.
Thank you.
But the problem is this, too, is now, I read the Bible, and in the Bible, God said everything is good and bad, and every not thought. And I just I'm a thinker, and I'm a problem solver.
Okay.
And it's not what you take, because there's God in your life.
Yeah, all right. I got you. We're going to finish up. We're going to finish up here. Thank you. Yeah, we're going to finish up here. The time is now 6:30. We're going to come to conclusion. Dr. Jones, can you just summarize your words in about 2 minutes, please, for us, what you want to leave us with?
So absolutely.
Okay. Did you submit a card? Okay. Usually at 6:30 we try to end, but I'm going to get to your question because... Okay, I got you. Come on. You got it. Go ahead.
Recirculating in health.
Recirculating dollars in health.
Go ahead.
All right, doctor. First of all, I need your card, okay?
I got you.
Because what I'm about to bring up, okay, you'll find out the reason why I need your card. Okay. First of all, there's no such thing as racism. But I go along with the racism word that you all use because that's the only way you understand it. There is a huge pocket of dollars in the hands of our senior citizens. Okay? Those dollars are through the health care system. Billions and billions of dollars. I belong to the musicians' clinic, which insures, all right, because I'm a musician, very good musician. Tell me.
All right.
Okay. They give you free insurance. I also have Medicare, Medicaid, and Aetna. Okay?
You're overly insured.
Right. Now, listen to this. I have to fight. I'm in the economic development of our people, which calls for recirculation of the dollar. I got to do detective work to find out where the blacks
I will get with you later. I will.
These people, wait, one second. These folks that are showing me right now, they never recommended me to a black.
I will get with you. I will get with you later, and I'll give you the name. I'll get with you later. I'll give you the name of every single black specialist that you need, although there are some specialties that are not represented by African Americans in New Orleans. Now, he was asking...
We need to provide that for everybody here. We need that resource provided for everybody.
So, I was being asked by Reverend Manning, what would I sum things up as? I would sum things up by saying, you absolutely must promote and ask for universal health care. If the person that you are going to vote for in the near future is not saying that he or she is a proponent of universal health care, they're caving to the powers that are sucking $1.3 trillion out of American pockets each year and simply are giving you a product that is not the same value as their counterparts in Europe and Canada get. We are 26th on the list of countries in terms of our healthcare delivery system.
Thank you, sir. Thank you. We appreciate you.